Hello everybody, my name is Mauricio Martinez. I am a fifth-year medical student at Universidad el Bosque and member of the General Surgery Interest Group. Today I'm going to be talking about the thoracic trauma from the ATLS. This is the literature that I used for this presentation. First we have the ATLS, the Advanced Trauma Life Support and Student Course Manual from the American College of Surgeons, the trauma book from Dr. Moore, Feliciano, and Mattox, and some articles that I used for this presentation, as this book from clinical algorithms in general surgery. The contents of this presentation, I'm going to talk about the introduction, the theology, the ATLS, the primary survey, secondary survey, other manifestations of chest injuries, and some conclusions to take home. I'm going to do a brief introduction to thoracic trauma. So we first know that thoracic injury is a common and potentially devastating component of acute trauma care. We must know that the chest takes up 1/4 of the total body mass and is therefore often subjected to injury during trauma from any etiology. Accounts for up to 35% of trauma-related deaths in the United States and encompasses a broad range of injuries that can cause significant morbidity and mortality. Consequences from trauma are hypoxia, hypercapnia, and acidosis. And the initial assessment and treatment of patients with thoracic trauma consists of the primary survey with resuscitation of vital functions, delayed secondary survey, and definitive care. In etiology, traditionally thoracic trauma is divided into 3 groups. First, we have penetrating trauma that compass missiles, fragments, knives, needles, and other objects. Blunt forces trauma, motor vehicle accidents, fails, resulting in compression, crash, injuries, rapid acceleration, deceleration injuries, and others that can be mixed etiology, like penetrating and blunt forces, heterogenic misadventure, and blasts, and the ingestion of toxic substances that indirectly can cause trauma, and medication of guilt. We have first here in the ATLS, the Advanced Trauma Life Saving Manual, that divides thoracic trauma approach into primary secondary survey. We know that the primary survey is the first priority in the management of thoracic trauma as the evaluation and stabilization of airway, breathing, and circulation, or ABC. We must include here the life-threatening injuries that I'm going to be talking later, and the secondary survey. There is a thorough head-to-toe examination that must be performed, and a full set of hematologic and metabolic laboratories to study and send to the patient. Here in the primary survey, as in all trauma patients, the primary survey of patients with thoracic injuries begins with airway, followed by breathing, and then circulation. Major problems should be corrected as they are identified, and here we must identify the life-threatening injuries as airway obstruction or rupture, tension pneumothorax, open pneumothorax, massive pneumothorax, and pericardial tamponade. First, in the airway component, we have the airway obstruction. Airway obstruction results from swelling, bleeding, or vomitus that is aspirated into the airway, interfering with the gas exchange from the lungs. Laryngeal injury can accompany major thoracic trauma or result from a direct blow to the neck or the shoulder restraint that is misplaced across the neck. Posterior dislocation of the clavicular head occasionally leads to airway obstruction. Alternatively, penetrating trauma involving the neck or chest can result in injury and bleeding, which produces obstruction. The signs and symptoms that we must find in these patients are air hunger, such as intercostal and supraclavicular muscle retractions. We must inspect the oropharynx for foreign body obstruction. Listen for air movement at the patient's nose, mouth, and lung field. Listen to for evidence of partial upper airway obstruction or a marked change in the expected voice quality in patients who are able to speak. And we must feel for crepitus over the anterior neck. Patients with airway obstruction may be treated with clearance of the blood or vomitus from the airway by suction. This maneuver is frequently only temporizing and placement of a definitive airway is necessary. We must palpate for a defect in the region of the sternoclavicular joint. We must reduce a posterior dislocation or fracture of the clavicle by extending the patient's shoulders and grasping the clavicle with a penetrating trowel clamp, which may alleviate the obstruction. Reduction is typically stable when the patient remains in a supine position. Tracheobronchial tree injuries are infrequent but potentially life-threatening. We must remember that the majority of tracheobronchial tree injuries occur within 1 inch or 2.54 centimeters of the carina. Uh, they can occur in the neck or thorax, resulting from either blunt or penetrating mechanisms. While these injuries occur most commonly in the neck and may be the result of either mechanism, intrathoracic airway trauma generally is related to blunt injuries from high-speed motor vehicle crashes. Most penetrating injuries to the cervical trachea, while straightforward to repair, may be associated with injury to vessels, esophagus, thoracic duct, and nerves. Signs and symptoms that we can find are hemoptysis, cervical subcutaneous emphysema, tension pneumothorax, cyanosis, incomplete expansion of the lung, and continued large air leak after placement of a chest tube that suggests a tracheobronchial injury. Bronchoscopy confirms the diagnosis. If tracheobronchial injury is suspected, we must obtain immediate surgical consultation. Immediate treatment may require placement of a definitive airway. Duration of patients with tracheobronchial injuries is frequently difficult because of the anatomic distortion from paratracheal hematoma associated oropharyngeal injuries and or the tracheobronchial injury itself. Advanced airway skills such as fiber optically assisted endotracheal tube placement past the tear site or selective intubation of the unaffected bronchus may be required. For such patients, immediate operative intervention is indicated. In more stable patients, operative treatment of tracheobronchial injuries may be delayed until the acute inflammation and edema resolves. Tension pneumothorax develops as a result of injury between the parietal and visceral pleural sheaths or injury of the trachea or bronchi. It may develop spontaneously or be iatrogenic, other than being caused by trauma, and is frequently encountered in closed pneumothorax. In tension pneumothorax, there is a one-way air entry into the pleural space, and the increased air pressure within the pleural space puts pressure on the lung and pushes the medicinum to the opposite side, which ultimately applies pressure on the other lung. Pushing the medicinum along with the heart and other vascular structures towards the opposite thoracic space is called mediastinal shift. Increased mediastinal shift impairs cardiac venous filling and present a life-threatening condition. Signs and symptoms that we can find are chest pain, air hunger, tachypnea, respiratory distress, tachycardia, hypotension, tracheal deviation away from the site of the injury. That's very important to identify. Unilateral absence of breathing sounds, elevated hemothorax without respiratory movement, neck vein distension, and cyanosis as a late manifestations. Tension pneumothorax requires immediate decompression and may be managed initially by rapidly inserting a large over-the-needle catheter into the pleural space. Due to the variable thickness of the chest wall in patients, kinking of the catheter, and other technical or anatomic complications, needle decompression may not be successful. In this case, finger thoracostomy, as shown in the lower image, is an alternative approach. Open pneumothorax is the result of a penetrating wound that creates a direct connection between the pleural space and the outside world. This equilibrates the intrathoracic pressures with atmospheric pressure and disrupts the physiological pressure gradient that drives respiration. We must remember that the thorax has a negative pressure that allows the lungs to expand. Signs and symptoms that we can find in these patients are pain, difficulty breathing, tachypnea, decreased breath sounds on the affected side, noisy movement of air through the chest wall injury. Open pneumothorax is commonly found and treated at the scene by pre-hospital personnel. For initial management of an open pneumothorax, we must promptly close the defect with a sterile dressing large enough to overlap the wound's edges. An occlusive dressing like a plastic wrap, etc., may be used as temporary measure to enable rapid assessment to continue. We must tape it securely on only 3 sides to provide a fluid voltage effect. As the patient breathes in, the dressing occludes the wound, preventing air from entering. During exhalation, the open end of the dressing allows air to escape from the pleural space. In taping all 4 edges of the dressing can cause air to accumulate in the thoracic cavity, resulting in a tension pneumothorax unless a chest tube is in place. We must place a chest tube removed from the wound as soon as possible, and subsequent definitive surgical closure of the wound is frequently required. Massive hemothorax results from the rapid accumulation of more than 15,000 of milliliters of blood, or 1/3 of more of the patient's blood volume in the chest cavity. Massive hemothorax is typically the result of more significant injuries, such as those involving the pulmonary vasculature, great vessels, or heart. Signs and symptoms that we can find are the neck veins may be flat due to severe hypovolemia, and massive hemothorax is suggested when shock is associated with the absence of red sounds or dullness to percussion on one side of the chest. Massive pneumothorax is initially managed by simultaneously restoring blood volume and decompressing the chest cavity, establish a large caliber intravenous line, infuse crystalloids, and begin transfusion of uncross-matched or type-specific blood as soon as possible. When appropriate, blood from the chest tube can be collected in a device suitable for auto-transfusion. A single chest tube from 28 or 32 French is inserted, usually in the fifth intercostal space, which is anterior to the mid-axillary line, and rapid restoration of volume continues as the compression of the chest cavity is completed. The immediate return of 15,000 milliliters of or more of blood generally indicates the need of urgent thoracotomy. Patients who have an initial output or less than this volume of fluid but continue to bleed may also require a thoracotomy. The decision is based on the rate of continuous blood loss, 200 milliliters per hour for 2 to 4 hours, as well as the patient's physiological status and whether the chest is completely evacuated of blood. Against the persistent need for blood transfusion as it is an indication for thoracotomy. Penetrating anterior chest wounds medial to the nipple line and posterior wounds medial to the scapula, the mediastinal box, should alert the practitioner to the possible need for thoracotomy because of the potential damage of the brain vessels, hilar structures, and the heart, with the association potential for associated potential for cardiac tamponade. We do not perform thoracotomy unless a surgeon qualified by training and experience is present. In this algorithm, we see that we must first do a history and physical exam. If we find pulses in the patient, we must initiate the ATLS assessment and resuscitation. As diagnosis methods, we can use a chest X-ray or an echocast. If the patient is not stable, we must proceed to the OR. And if we have an hemothorax, we must perform an anterolateral thoracostomy. If the patient has no pulses, we must need a resuscitative thoracotomy. Cardiac tamponade is compression by the heart of the heart by an accumulation of the fluid in the pericardial sac. This results in a decreased cardiac output due to the increased inflow to the heart. Cardiac tamponade most commonly results from penetrating injuries of a blunt injury that can cause the pericardium to fill with blood from the heart, blood vessels, or epicardial vessels. Signs of pericardial tamponade characteristically present in 3 phases. First, observed in tachycardia and increased systemic vascular resistance, followed by decreased cardiac output, and finally complete circulatory collapse. Focused assessment with sonography for trauma or ECOPAS is a rapid and accurate method of imaging the heart and pericardium that can effectively identify cardiac tamponade. FAST is 1995% accurate in identifying the presence of pericardial fluid for the experienced operator. Pericardial tamponade is recognized early enough in the first two phases. Pericardiosynthesis can be performed as temporary decompression before definitive repair. If, however, the patient is already in obstructive shock, the patient requires an emergency thoracotomy. As we can see in this algorithm again, if we have a cardiac tamponade, we must we must do a median thoracotomy. Traumatic cardiac arrest in trauma patients who are unconscious and have no pulse, including pulseless electrical activity, ventricular fibrillation, and asystole. Circulatory arrest is diagnosed according to clinical findings. Unconscious and no pulse and requires immediate action. Every second counts, and there should be no delay for ECG monitoring or echocardiogram. We must start closed CPR simultaneously with ABC match. Secure a definitive airway with orotracheal intubation without rapid sequence induction. We must administer mechanical ventilation with 100% oxygen. To alleviate a potential tension pneumothorax, we must perform bilateral finger or tube customies. No local anesthesia is necessary as the patient is unconscious. We must continually monitor ECG and oxygen saturation and begin a rapid fluid resuscitation through large bore IV lines or intraosseous needles. Administer epinephrine 1 milligram, and if ventricular fibrillation is present, we must treat it according to advanced cardiac life support protocols. According to local policy of the availability of the surgical team skilled in repair or of such injuries, a resuscitative thoracotomy may be required if there is no return of spontaneous circulation. If there is no surgeon available to perform a thoracotomy and cardiac tamponade has been diagnosed or is highly suspected, a decompressive needle pericardiocentesis may be performed, preferably under ultrasound guidance. Here in this other algorithm, we have the approach of traumatic cardiac arrest depending from the mechanism of injury. If you have a patient with blunt injury and no vital signs en route or in the emergency department, we must pronounce the death. The patient lost the signal bites en route. There must be performed a cardiac ultrasound or EKG. If the cardiac ultrasound shows no cardiac activity, we must pronounce death. If the ultrasound shows positive cardiac activity, we must consider resuscitating the vascular balloon occlusion of the aorta. And if we have the ultrasound positive for fluid, such as tamponade, we must perform an emergency thoracotomy. If the trauma is penetrating, if the patient has no vital signs or CPR more than 20 minutes, we must pronounce the death. If we have the loss of vital signs en route or in the emergency department, we must determine two things. If we have chest injury, we must perform an emergency thoracotomy. If we have an abdominal injury suspecting abdominal aortic injury, we must consider resuscitative endovascular balloon occlusion of the aorta. In the secondary survey, as I told you earlier, once immediately life-threatening injuries have been managed and the patient ABCs have stabilized, a thorough head-to-toe examination must be performed. A full of hematologic and metabolic laboratory studies should be sent. The secondary survey not only allows for a more complete picture of the patient condition, but also for the discovery of other non-emergent but possibly life-threatening injuries. The components of the secondary survey are the evaluation of the Glasgow Coma Scale, the head-to-toe examination, basic laboratory studies, chest X-ray, consideration of an ECOPAS, further imaging based on clinical suspicion. in this secondary survey, first we have simple pneumothorax. It's one of the most common pathologic conditions encountered with thoracic trauma. That is the non-tension pneumothorax, with an estimated incidence of 20%. Simple pneumothorax occurs as air slowly leaks from the lung parenchyma. Uh, Air in the pleural space disrupts the cohesive process between the visceral and parietal flora, allowing the lungs to collapse. A ventilation perfusion defect occurs because the blood that perfuses the non-ventilated area is not oxygenated. Signs and symptoms that we can find are tachycardia, hypoxia, decreased breath sounds, or crepitus. And what if the patient is symptomatic, the thoracostomy is indicated. In this X-ray, we can see the demonstration of a seemingly normal portable chest X-ray after a motor vehicle collision, but with evidence of bilateral apical pneumothorax discovered in the chest CT, as shown on the right image. Any pneumothorax is best treated with a chest tube placed in the fifth intercostal space, just anterior to mid-axillary line. Observation and aspiration of a small asymptomatic pneumothorax can be appropriate, but a qualified doctor should make this treatment decision. After inserting the chest tube and connecting it to an underwater seal apparatus with or without suction, a chest X-ray examination is done to confirm appropriate placement and re-expansion of the lung. Ideally, a patient with a known pneumothorax should not undergo a general anesthesia or receive positive pressure ventilation without having a chest tube inserted. In selected circumstances, such as when a subclinical pneumothorax has been diagnosed, the trauma team may decide to carefully observe the patient for signs that the pneumothorax is expanding. The safest approach is to place a chest tube before a tension pneumothorax can develop. A hemothorax is a type of pleural effusion in which blood is less than 1,500 milliliters accumulates in the pleural cavity. Non-massive hemothorax occurs by injury to lung parenchyma, intercostal vessels, or other chest wall vessels. Bleeding is usually self-limited and does not require operative intervention. We must expose the chest and cervical areas and observe the movement of the chest wall. Look for any penetrating chest wall injuries, including the posterior thorax. Assess and compare breath sounds in both hemithoraces. Typically, dullness to percussion is heard on the affected side. We must obtain a chest X-ray with the patient in the supine position. A small position of lung will be identified as an homogeneous opacity of the affected side, as we can see in the image in the right hemithorax. We can see a small hemothorax. An acute hemothorax that is large enough to appear on the chest X-ray may be treated with a 28-32 French chest tube. The chest tube evacuates blood, reduces the risk of a clotted pneumothorax, and allows for continuous monitoring of blood loss. A flayed chest occurs when a segment of the chest wall does not have a bony continuity with the rest of the thoracic cage. Diagnosis sometimes is difficult because the decreased respiratory effort combined with congestion and atelectasis that may limit movement of the chest wall. And a thick chest wall musculature that may also limit visualization of chest movements. This diagnosis is suspected in patients with chest wall pain after injury, crepitus chest wall asymmetry, paradoxic breathing, and dyspnea are often present. Chest radiographs can identify many rib fractures, particularly significantly displaced fractures. External fractures and non-displaced rib fractures are often only identified with CT imaging. The management of these injuries requires a multidisciplinary approach with three primary components: pain management, respiratory therapy, and mobility. Anesthesia, nursing, and respiratory and physical therapy all play a significant role in the successful management of patients with chest wall injury. Pulmonary contusion often occurs in conjunction with chest wall injury. The contused lung is often damaged and unable to participate in the gas exchange of respiration. In adults, pulmonary contusion is most often encountered with concomitant rib fractures and is the most common potentially lethal chest injury. Pulmonary contusions are common and range from clinical silence to causing severe respiratory distress. Uh, although they can occur with any chest injury, they are highly associated with rib fractures, especially plate chest. The clinical symptoms include respiratory distress, increased work of breathing, hypoxia, and less commonly hypercapnia. One of the hallmarks in these clinical symptoms and radiographic findings increase of the time over time, generally over 3 days, and resolve in 1 week. Supportive treatment is typically all that is necessary, including judicious film administration, pulmonary toilet, and supplementation. Mechanical ventilation is indicated for respiratory failure, refractory to less invasive therapies. Blunt cardiac injury ranging from ranges from insignificant bruises of the myocardium to cardiac rupture. Pathology can be caused by direct energy transfer to the heart or by a mechanism of compression of the heart between the sternum and the vertebral column. Cardiac rupture during external cardiac massage as part of cardiopulmonary resuscitation can occur. Clinically significant blunt cardiac injuries include cardiac rupture, including ventricular or atrial, septal rupture, valvular dysfunction, coronary thrombosis, and caval avulsion. These injuries manifest as tamponade, hemorrhage, or severe cardiac dysfunction. Septal rupture and valvular dysfunction um, can initially appear without symptoms but later demonstrate the delayed sequela of heart failure. In this algorithm, I want to show you that first we must perform an EKG, troponin, and uh, we must search for pre-existing cardiac abnormalities or pre-hospitalizary history. If we have a normal EKG and troponin, we must know that the patient can continue trauma workup, and we must not perform any other uh, treatment, especially directly to the heart. If you have abnormal EKG or abnormal troponin, and the patient is hemodynamically stable, we must perform a cardiology consult. Uh, we consider an echocardiography, and we must perform anesthetic management peritology. And if the patient is hemodynamically unstable, we must perform the ATLS and ACLS approach. We must admit the patient in the ICU. We must perform a cardiology consult. We must perform echocardiography. We must consider an specific management peritology. The specific management is different in the different lesions that we can find. We have a valve, septum, or ventricular wall injury. We must perform cardiothoracic surgery consult. The acute coronary syndrome, and we must perform ACLS protocols, cardiology consult, forcible catheterization with stent, and we must avoid thrombolytics. If you have a cardiac dysfunction, we must call cardiology consult and echocardiogram. If we have arrhythmias, we must perform the ACLS protocols. If the patient is tachycardic, assume a hemorrhage until proven otherwise in the setting of trauma. A traumatic artery rupture is a common cause of sudden death after a vehicle collision or fall from a great height. Maintain a high index of suspicion prompted by a history of decelerating force and characteristic finding on the chest X-ray films that may escape into the mediastinum, but one characteristic characteristic shared with all survivors is that they have a contained hematoma. Persistent or recurrent hypotension is usually due to a separate, unidentified bleeding site, although a pre-rupture of a transected aorta into the left chest does occur and can cause hypotension. It usually is fatal unless the trauma team can repeat within a few minutes. Unless the injury is severe, signs and symptoms are often vague, and aortic disruption is instead suspected based on the mechanism of trauma or the associated injury pattern, and is confirmed by radiographic studies. Chest X-ray may suggest aortic disease through findings of hemorrhage such as pneumothorax or mediastinal widening. Thoracic CT can scan with IV contrast remains the gold standard, preferably using a trauma or angiogram protocol. In the unstable patient, transesophageal cardiography is also an option and further provides the opportunity for cardiac and valvular evaluation. Helical contrast enhanced computer tomography of the chest has proven to be an accurate screening method for patients with suspected blunt aortic injury. CT scanning should be performed liberally because the findings of the chest X-ray, especially the supine view, are unreliable. If patients are equivocal, aortography should be performed. Heart rate control with a short-acting beta blocker to a goal heart rate or less than 80 beats per minute, and blood pressure control with a goal mean arterial pressure of 60 to 70 millimeters of mercury is recommended. When beta blockade with a small is not sufficient or contraindicated, a calcium channel blocker like nicardipine can be used. If this fails, nitroglycerin or nitroprusside can be carefully added. Hypotension is an obvious contraindication to these medications. In this slide, I wanted to show you all the treatment. We must perform a pain control, a heart rate control, as I told you, and the repair. Here in this algorithm, we have the suggestive history or physical examination for a thoracic aortic injury. We must perform afterload reduction unless the blood pressure of patient is unstable. We must do screening with a chest X-ray, or a CT with appropriate protocol. And if these are strongly suggestive or equivocal, we must perform an orthography. If the orthography is positive, we must perform a treatment that can be immediate and is an open approach, or a delayed approach, or endovascular approach, or we can perform a delayed approach. If the orthography is negative, we must treat other injuries, and if it is trivial, we must repeat the studies time. Traumatic diaphragmatic injury is among the most difficult diagnoses to make in a traumatic setting. Traumatic diaphragmatic ruptures are most commonly diagnosed on the left side, perhaps because the liver obliterates the defect and protects it on the right side, whereas the appearance of displaced bowel, stomach, and or nasogastric tube is more easily detected in the left chest. Occasionally, the condition is not identified in the initial X-ray film or subsequent CT scan, is in which case an upper gastrointestinal contrast study should be performed. The appearance of peritoneal lavage fluid in the chest tube drainage also confirms the diagnosis in patients who have undergone diagnostic peritoneal lavage. When an injury is discovered, primary repair can usually become accomplished and can be performed either from an abdominal or a thoracic approach. If the defect is too large to close primarily, placement of mesh or cadaveric or bovine graft is appropriate. Blunt esophageal rupture. First, we need to know that esophageal injuries, while rare, are nonetheless serious, especially when they occur in the infrathoracic esophagus. Due to the protection of the bony thorax, esophageal injuries are more common in the neck than the thorax. Although rare, blunt esophageal trauma caused by a forceful expulsion of gastric contents into the esophagus from a severe blow to the upper abdomen can be lethal if unrecognized. This forceful injection produces a line tear in the lower esophagus, allowing leakage into the mediastinum. The resulting mediastinitis is an immediate or delayed rupture into the pleural space causes an empyema. The gold standard diagnostic modality is the complementary use of an esophagram, a fluoroscopic or CT, and esophagoscopy, each alone missing 50% of injuries but achieving near 100% sensitivity in combination. Treatment of esophageal rupture consists of wide drainage of the pleural space and mediastinum with direct repair of the injury. Repairs performed within a few hours of injury improve the patient's prognosis. Additionally, surgical intervention was recommended if the injury was diagnosed within 24 hours, whereas medical therapy was recommended for delayed diagnosis. Furthermore, primary repair should be attempted not based on timing but rather tissue viability. Pleural, pericardial, diaphragmatic, or muscle flap reinforcement can be used to aid in tissue protection and as can endoscopically placed negative pressure therapy. When the esophageal injury is truly too large to repair, resection and diverting esophagostomy may be required until definitive interposition or conduit creation can be performed. Endoscopically placed esophageal stent therapy is also emerging as a viable treatment modality. Stents have demonstrated 90% effectiveness with iatrogenic esophageal injuries. However, it is unclear if this data is applicable to traumatic structures. Now I'm going to talk to you about other manifestations of the chest injury. First, we have the subcutaneous emphysema that can result from airway injury, lung injury, or rarely blast injury. Although this condition does not require treatment, clinicians must recognize the underlying injury and treat it. If positive pressure ventilation is required, consider performing a tracheostomy on the side of the subcutaneous emphysema in case tension pneumothorax develops. As we can see in the image, we can see that in the left thorax patient, the different lines shows a little bit of air in the soft tissues of the chest that can indicate a subcutaneous emphysema. Uh, Another thing that we can find associated with a crush injury to the chest or traumatic is traumatic asphyxia that include upper torso, facial, and arm plethora with petechia secondary to acute temporary compression of the superior vena cava. Um, Massive swelling and even cerebral edema may be present. Associated injuries must be treated. This is the result of a protracted crush injury to the upper torso or epigastrium. And finally, we have the rib, sternum, and scapular fractures. I talked about it before at the plate chest, but here I'm going to talk about that includes the multiple or displaced rib fractures, scapular fracture, sternal fracture, and posterior sternoclavicular dislocation. Relief of pain is important to enable adequate and effective ventilation. Intercostal block, epidural anesthesia, and systemic analgesic are effective and may be necessary. Early and aggressive pain control, including the use of systemic narcotics and topical local or regional anesthesia, improves the outcome in patients with rib, sternum, or scapular fractures. To take home, we must understand that thoracic injury is common in the polytrauma patient and can pose life-threatening problems if not promptly identified and treated during the primary survey. As with the management of all traumas, a thoracic trauma evaluation requires a systematic approach with prioritizing airway, respiration, and circulation, followed by a focused secondary survey. Once the primary survey is complete and stable, the secondary survey is crucial in uncovering most thoracic injuries and guiding effective care. Thank you so much for listening to these presentations. This is my info. If you want it, thank you so much. Good night.